Hello, my name is Daphne Ward, and I am the Executive Director of the Southern AIDS Coalition. And I am so honored to have this opportunity to share with you during this series of events in honor of MLK Day 2021. Thank you so much to the Hilton Head MLK Committee for Justice for this invitation and opportunity just to share as we are all reflecting right now on the life and legacy of Dr. King, especially in these times that we sit in where we really do need to let ourselves have some time to really process what these moments mean, where we are socially and politically, culturally as a country, and also what we can learn from the legacy of King, where he may have challenged systems and challenged us to step up, to be courageous, and to ask questions. And so I'm excited to have an opportunity just to really reflect a bit about health disparities and the way that they show up, and the fact that there are, as I said in my title, there are layers to this. It is not just a simple issue that is going to be addressed overnight or resolved overnight, but it's definitely going to take some time. And so I just want to take a few minutes and talk through some thoughts that I have in hopes that you may even think more around the ways that you see health disparities showing up in your community and our communities and how we can address those. So, as I mentioned, I lead the Southern AIDS Coalition, which is a coalition of individuals living with and impacted by HIV, community-based organizations, pharmaceutical leaders, as well as legislative decision makers, agency decision makers across the region. And what we do is we really work collaboratively as a coalition to elevate conversations around laws and policies that have implications for communities that are most impacted by HIV. We truly believe that every person in the country, but specifically in the 16 southern states and Washington, D.C., the geographic area that we serve, should have access to high quality healthcare and essential support services that's free from stigma and discrimination. So we believe that we have to effectively address the way that implicit bias and judgment and all of these other things show up and create harm in our health and social service systems. We envision a South where every person understands their risk for HIV transmission, where every person has access to routine screening and access to a full range of prevention interventions and harm reduction services. So that's the lens I'll bring to this conversation today. My experience is coming from a place around HIV, but not just HIV, because as I get into my conversation, we'll really look at how HIV is one of but many areas where we see inequitable impact on communities that have been historically marginalized in this country. And if we're going to talk about health disparities, if we're going to talk about where we have to place our focus around healthcare in this country, we have to acknowledge healthcare as the civil rights issue as our time. Access to resources to take care of oneself, to prevent disease, to receive care for chronic conditions, to have access to treatment and resources that can sustain life, to have access to mental health services, substance use services, those things that folks need in order to thrive and live healthy and independent lives. That is, it's so closely interwoven and interconnected with the core tenets of the civil rights movement that Dr. King was such a fundamental leader of. And we cannot lose sight of that connection as we have these conversations, as we talk about why people need to have access to healthcare, why people need to have access to physicians and healthcare providers who will treat them with respect, why we have to change our policies and tear down systems that perpetuate stereotypes and continue to do harm for certain communities, where there's no language justice in our healthcare systems, where people can't get translation services and culturally competent care. That is fundamental to civil rights. And that is a part of being fully free that we have to recognize when we have these conversations. Right now, as we sit in the midst of conversations about vaccines and we're talking about COVID, we would be remiss if we didn't pause and speak to where one of the largest challenges exist in our healthcare system, specifically for communities of color, Black communities, Latinx communities, American Indigenous communities that have been repeatedly and historically abused and harmed by our government and by entities that have been publicly acknowledged. And the U.S. Public Health Service syphilis study at Tuskegee is the prime example that many of you are well aware of. I want to take a moment and say and just give a little side note. Please stop referring to this as the Tuskegee experiment. It implies then that the onus and ownership of this lies with Tuskegee University or the city of Tuskegee, when at the end of the day, this was an experiment by the United States government that was later apologized for, and there have been some level of payment set up for the families and individuals impacted by this study. But from 1932 to 1972, the U.S. Public Health Service was engaging in studies in Tuskegee, Alabama, where Black men, poor Black men, were known to be living with syphilis, were known to be suffering with the symptoms, the debilitating conditions related to syphilis, and were not provided with treatment. And this is when you hear about, quote, the Tuskegee experiment, this is what folks are talking about. The U.S. Public Health Service syphilis study at Tuskegee caused significant harm, did significant damage, is but one of many examples of the way that our healthcare systems have created a culture by which the lives of those who are Black and brown, who are poor, who are in lower communities with limited resources, where they are not as valued in our healthcare system. And it's going to take a tremendous amount of work to change that. We can't talk about that. We can't talk about the U.S. Public Health Service study at Tuskegee. We can't talk about COVID-19 vaccines. We can't talk about any of those things without truly providing some context around where people are really struggling. Why is there a lack of trust in a vaccine that could likely save someone's life? What we know to be sure is that in 2020, Black and Latinx and Indigenous people were far more likely to die as a result of COVID-19 than their white peers. And now what we have to realize is that we could take this statistic and lay it over a number of diseases, and actually the disparity would be even greater. But when we're talking about why are people so hesitant, why are people so afraid, or even if we want to get to why are people so angry that certain folks don't even see the value in wearing masks, we are talking about whose lives are valued, whose lives are taken into account when we're talking about opportunities for care, when we're talking about opportunities to get life-changing treatment, experimental drugs that we hear about being provided maybe to someone who's in an elected office or of great affluence. Were those same opportunities provided to someone who's Black or brown, or someone who maybe didn't have access to the same level of resources financially? We have to look at the layers of this and really have a real talk with ourselves about why things are the way they are in this regard. And we're speaking specifically to COVID, and I want to lift up COVID because what we're seeing happen in COVID-19, suddenly everyone in the country was talking about health disparities. And for many Americans, it was the first time this conversation was happening. But what we know to be true is that health disparities have existed in this country since this country was founded. Since people of color, since Black folks were here and enslaved, that is where we see the onset of health disparities, where American Indian and Indigenous people were even previous to the syphilis study, in the decades and centuries leading up to that, where we were seeing communities of people intentionally sickened by the government, intentionally harmed by healthcare providers, by doctors who were introducing illness to certain people because of government and political decision making. That is at the heart of health disparities in this country. And until we address the reality of that, we will not see a change when it relates to how everyone can receive equitable care. So this slide here shows what we know to be true around chronic conditions that are extremely common in Black communities, extremely common in America, sadly, but even more so if you look at the age rate. Look at the age at which you see African Americans being diagnosed and living with diseases versus their white peers. This is just an example. And when you think about the fact that by the age of 50, we're talking about in the Black community, more than half of the community living with high blood pressure. Diabetes, nearly a quarter of the community living with diabetes. And we have to understand that some of this, of course, doctors will say, well, it's genetic and it runs in families. And we understand those things to be true, but that does not take us away from needing to really look at what is happening in our communities, what is being perpetuated, maybe in lifestyle, from people having resources to healthy foods, how is stress showing up and causing this? There are a lot of layers that have to be discussed when we're talking about why we're seeing more common diagnosis of these conditions in our community. And let's just pause and say that this is just those who are diagnosed. For those who don't have access to health care, for those who, for good reason, distrust the healthcare system and are not engaging in healthcare, there are millions of people who are undiagnosed for a range of chronic conditions that could eventually kill them. And we also have to acknowledge that African Americans are more likely to die at early ages from all causes. So aside from high blood pressure and diabetes and stroke, African Americans are more likely to die at early age from just about any cause. And so we have to also keep that in mind and overlay that. There's layers to this. Overlay that with the conversations we're having right now about COVID and the communities that are being disproportionately impacted. I have to pause and stop and talk specifically around HIV for a moment. And I lift up this recent study that the CDC released because what we see here, I have underlined where we see South Carolina showing up in the top when it relates to HIV-related deaths. Highest HIV-related deaths by jurisdiction, we see Mississippi, Puerto Rico, and South Carolina. Rates of HIV-related death by race and ethnicity among both white and Black people, South Carolina's first among whites and third when it comes to HIV-related deaths by race when it pertains to Blacks or African Americans. And I think this quote truly sums it up. HIV-related deaths, prevalence of HIV infection, greatest by race, ethnicity among Black persons and by US region in the South. Why African Americans? And why the South? Higher levels of poverty, unemployment, uninsured persons, challenges associated with accessing care, and HIV-related stigma. All of these things, the CDC is saying in this report, can be attributed to the rates that we're seeing in the South and among Blacks. So, the South, whether you know it or not, holds the greatest rate of new HIV infection in the United States. More than half of all new HIV diagnoses in the US is in the Southern United States. And so why is that? This is one layer that our colleagues at AIDS View and our partners from Duke University and research that we did looking at where do people have to go to get services. And this is just stigma reduction services. So if someone wanted to engage with a provider around services to help them deal with stigma, the harms that come, the mental health harms, the challenges to accessing care that come from stigma, that folks are in service deserts when it comes to getting those supportive services, many having to drive 30 minutes or more. So you're talking about nearly 40,000 people living with HIV in the South, having to drive more than 30 minutes to access stigma reduction services. And think about that. Think about what that means for someone who may or may not have independent transportation. Think about that for someone who may be relying on friends or family who don't know their HIV, who don't know this person's HIV status, and having to disclose in order to get transportation. Think about those who live in rural communities where there's no public transportation to get you to the supportive services you need. So currently, there is a federal ending the HIV epidemic plan. And I would love to get into that. And maybe we can have another conversation about the ending the epidemic plan. But I wanted to note that the federal government has identified 48 counties across the country where if we could address HIV in those 48 counties, if we could significantly reduce new infections, get people linked to care, make sure that treatment is sustainable and accessible, effectively engage communities and link people to the supportive services, those integrated services that they need, then we could end HIV in this country. 48% of those are in the South. So 48% of the 48 highest burden counties in the federal ending the HIV epidemic plan are in the southern United States. So let's talk a little bit about those things that are mentioned in the CDC's quote. What do we attribute to these high rates of prevalence of HIV, these high rates of HIV-related death in these jurisdictions? Well, it's right here. 67% of those target counties, people are living in poverty, right? It's higher than the national average. And if you look at it, 73% of those 48 counties, people uninsured is higher than the national average. So we're talking about poverty and we're talking about uninsured individuals. And sadly, in this country, your risk level around not having insurance, your risk level of not having regular medical care is tied to your ability to pay. So poverty and being uninsured go hand in hand and are perpetuating issues in this country that are just detrimental to the very lives of so many people, specifically in the South and in South Carolina. So in all of the 7 states that you see here that are the focus of the plan to end HIV in America, the percent of people living with poverty is higher than the national average. In 6 of the 7 states, percent of people uninsured is higher than the national average. So let's talk about insurance, since we're talking about the layers. If you look here, the light teal states on the map are the states that have not adopted Medicaid expansion. These are the states where it is still a challenge for people to access the health care that they need. States where state governments have decided that rather than expand Medicaid and expand and increase access to key health services for millions of people across these states, they'd rather not do so. And as a result of that, we'll continue to see the perpetuation of individuals unable to access the health care they need, unable to access the resources to get the health care they need. People are stuck outside of the system of care. The wall has been put up. We have demonstrated in these states that there's a lack of care and concern about the well-being of every individual in that state, that only certain people are worthy of health care. And that, again, is another conversation for another day. But please note where South Carolina sits on this map. The status of Medicaid expansion in southern states is clear. If you lay these maps on top of one another, if you look at where you have the highest prevalence of HIV, if you look at where you have the greatest number of COVID-related deaths, if you look at where you don't have Medicaid expansion, you'll see that all of these things go hand in hand. Let's add on top of that sex education in our schools. You might be asking, what does that have to do with anything? There is a correlation between states that have sex education that is inclusive and comprehensive, and where we also are seeing rates of unintended pregnancy and other STIs and health HIV and health-related challenges related to reproductive health. And if you look here, many of our states, they have sex education and HIV education, but they also, if you see that white stripe, states are stressing abstinence in sex ed. Of course, we would love for our kids to be abstinent, but we also realize that it is important for young people to have all of the health information so that they can make wise decisions. We have also seen research that's shown that young people who receive abstinence-only education are far more likely to engage in sexual behavior that puts them at risk because they don't always receive all of the information. So they're often placed at greater risk for sexually transmitted infections, HIV, and unintended pregnancies. Additionally, if we want to talk about health disparities, if we want to talk about civil rights, then we do have to talk about the way this shows up for LGBTQ Americans as well. There are layers to this, and there are folks who are still being discriminated against in our healthcare system and across systems due to their sexual orientation and gender identity. My point in sharing this slide is that a medical provider, anyone providing healthcare and social services, should be able to provide competent, effective, non-judgmental care. But if you look at the gray states on this slide, none of these states have instituted protections against discrimination for individuals of LGBTQ experience. And so we have to note that when we're talking about the layers of health disparities and how they're perpetuated in this country. Another one of my favorite slogans in this work when it comes to talking about folks who are living with HIV and making sure they have what they need, shout out to AIDS Alabama and Birmingham, Alabama, is housing is healthcare. Housing is healthcare. And we're living in states, specifically in the South and across the country, where there are limited to no protection from discrimination for low-income renters. So low-income renters who are not receiving protections from discrimination in their housing, who are living in states with with no Medicaid expansion, with limited access in rural communities where there is, an inability to get back and forth to where you may need to be. These are the layers that we're talking about on top of a system of historic discrimination and inequity. This also extends to the way that we see healthcare intersect with with law enforcement, with our justice system. And I note this because we can't talk about disparities around race and not talk about this because we see the cyclical impact of discrimination, the way it shows up in all aspects of care. And so it extends even to the way that we see our systems interacting with young people disproportionately. So if you look at South Carolina specifically, this came from the Sentencing Project. And this data is telling you that where you might see 171 Black youth arrested in an instance and entered into a juvenile detention system, then you would see 71 white youth for every 171 Black youth at a ratio of 2.4. So it's just really important to note how we see these inequities show up in various and intersecting systems in our communities. I believe that this quote, while it speaks to how we end the HIV epidemic in the South, it truly speaks to what we need to end health disparities. We must end inequality to end the inequities. And I'll close with this. How do we change this? What can we do? There's going to have to be a systemic shift, and it's nothing that one person can do alone. We have to respond to barriers that are created by our state and local policies. And that means that we have to ask the hard questions. We can't just show up to the polls and vote. We have to show up in the State House. We have to show up in our elected officials' inboxes and their voicemails, asking questions, challenging them, telling our stories. We have to fully integrate services that are actually needed. When someone comes in, say, for an HIV test, do they need access to housing? Do they need mental health services? Is there a substance use diagnosis that we could support them in? Is there any level of support we could provide that could help them? Are they employed? Do they have employable skills? Is job readiness an option? Is there something we can link people to? One of the federal programs, I believe it was SAMHSA, created a program with the term "no wrong door." And that's how I try to live my work and encourage the partners that we work with to consider that whoever knocks on your door, whoever comes to you in need of services, that there's no wrong door. if they knock on my door and they're looking for HIV care, and they also need housing, and they also need counseling around domestic violence, or they need an intervention in that regard, if they need support with childcare, there shouldn't be a wrong door in social services and in medical services. So whoever comes to me, I can link them to what they need. We have to acknowledge trauma as a barrier to engagement. There's no reason to demonize people who are afraid of the vaccine. We have to demonize a system that's created that rightful fear and indignation around vaccine usage. While we know the vaccine, I'm honored to know so many people who've worked on it. I trust the science. I'm excited to be able to get it. And I also completely understand where there is fear and apprehension. And rather than create judgment around that, we have to acknowledge that trauma and remove the barriers that are allowing that trauma to be perpetuated by the way that care is delivered. Assess practices within our organizations. So if you're with an organization, if you're a provider yourself, if you're on a board of directors of an organization that provides services, or if you're even just a client who goes in and receives services, find ways to call out and eradicate racism and white supremacy in those spaces, because that is a big part of the issue that no one wants to talk about. Mandate trainings that address bias and stigma in service delivery. If you have the power in any such way to do that, even if you're in a church, have those conversations in your faith settings, even on Zoom. Meaningfully include community input at every step. Ask people why they're not engaging with you in care. Find out why people aren't going to the doctor. Some of it is because people have an understandable fear. Some of it is an inability to pay. Make sure that people in your community know about volunteers in medicine, know about other resources that are available to support them. Let's make sure that our community is providing pathways for employment, promotion for those from communities that are most impacted by HIV and other health conditions. People want to live healthy and independent lives. There is an opportunity in our communities to support one another. There's an opportunity here in the Low Country to really find ways where we can build community and start to make demands of our officials to make sure that our laws reflect the needs of the communities here, that the constituents' needs are the priority over any type of political agenda. We have to make demands in that way if we truly want to end health disparities. I share this book, The Failures of Integration, because it was really important in noting in the study of this book, which was really about housing integration. There were some conversations with folks in segregated communities. And what it found was that there were people, specifically white people in all white communities, who were very transparent in that they didn't have an issue. They wouldn't have an issue in having any, Black people move in to their communities. They didn't have any issue. It wouldn't be a challenge. However, they had no one in their lives that was Black. So it was really just a conversation where they were saying, yeah, if it happens, I think it'll be okay. But no, I don't know any Black people. So I lift that up because it's the book is far deeper than that. But I lift that up as a challenge because so many times we have these conversations about supporting things and being supportive, or even being okay with things that or policies or changes in our communities that may add people to the mix that we're not familiar with, that may add a new dynamic. But something as not basic, but something as significant, and also should be basic and simple, as having a next door neighbor that looks different than you, of a different race or culture, is something that will say, oh, it'll be fine, but not having any insight or spending any time getting to know anybody outside of our own likeness. And so I issue that as a challenge. If you want to hear about people's experiences with the healthcare system, if you want to know why people are afraid and dealing with these barriers and dealing with these barriers and challenges, ask and have conversations, listen, and it's really important that we do more of that. So yes, there are layers to this. There's a lot of work to do. I'm excited to do this work locally, at state level, and regionally and nationally. And I would love to do more here in our backyard, here in the Low Country of South Carolina, Hilton Head, Bluffton area. And so please reach out. My email address is here. You can follow us on social media. And I thank you so much for your time. Thank you. I appreciate you tuning in. Please tune in for the remainder of events, and I'm sure these recordings will be available. So hope you go check them out as well. Thank you all so much. And let's all continue to reflect on and then challenge ourselves to come to a place of action so that we might live the legacy of Dr. King. Thank you.